I'll be your MC for today. So I'll just do a short intro first. So today will be our first prime for gynecology. We'll have two speakers for today, basically two sessions with a 15-minute break in between. So before we begin, let's recite Umul Kita Al-Fatihah. Okay, I think as it's already 8:30, without further ado, I would like to welcome Prof. Zalina for the first session. Silakan, Prof.
Assalamualaikum, and I would like to thank you all for inviting me for this session. I have asked two of your colleagues to present since they have prepared. I think I'll give chance to show their talent and the effort taken to prepare the presentation. In fact, I have prepared one presentation as well. And if we have time, we can proceed with doing some MCQs, OBA, and PMP if we have time. Okay, so basically this one is the title given to me is approach of AUB, right? So I'll be going very briefly and just discuss how are you going to approach the case. Okay, I think we should start with your presentation. To presentation, right? You all prepared?
Yes, Prof. Nampak screen tak? Fine. No. Fine. Okay, thank you everyone. My name is Muhammad Rusyaidi, currently in surgical posting. Thank you for being given this opportunity to present. If there is any flaws in any part of the presentation, I hope Prof may interrupt and maybe can correct me, inshallah. Okay. So the topic is for me it's quite huge to talk for the span of 10 minutes, but I'll try my best. Okay, so endometrial bleeding. Okay, let's start with the definition first. So it's defined as the menstrual bleeding of abnormal frequency, duration, or quantity, or the volume outside of the pregnancy. Okay, so it is about approximately about 3 to 30% among reproductive age women. Okay, so let's go first for the normal one. So we can see the quantity of blood loss of less than 80 ml, which averaging about 30 to 35, with flow duration of 2 to 7 days, average of 4 days, and the cycle length of 21 to 35 days. Okay, these are the normal menstrual periods. So that's why in the history taking later, we need to know what are the quantity, flow, and cycle, so that we can extract the abnormality in their menstrual period. Okay, these are the phases of reproductive cycle. I think everyone is already know what are the phases. Okay, so let's look at some of the terminology. Okay, so the FIGO actually differentiate there is a system 1 and system 2. So the system 1, they quantify the amount, the type, the regularity or frequency of the bleeding.
Okay, you can present because you presented, you prepared very good. You can take your time. I give you 15 to 20 minutes. No hurry. Okay.
Okay, Prof. So the heavy menstrual bleeding. So increased daily a total of more than 80 ml. And then do we have the intramenstrual bleeding? When patient is having a very regular cyclical and there's a bleeding intermenstrually, so we call it IMB, frequent and also infrequent amenorrhea. So actually we have eliminate the older term like menorrhagia, oligomenorrhea. So we have to use this newer term. Okay. Next, so this is a more on the system 1 where they will do a series of checklists for the frequency, duration, and regularity. Okay, now we go to the system 2. System 2, we look at the cause of the AUB. Okay, so we go have a structural and non-structural. So this is an amazing mnemonic. So PLM, polyp adenomyosis leiomyoma malignancy. Non-structural, we have coagulopathy, ovulatory dysfunction, endometrial iatrogenic, and not yet classified. Okay, so these are some of the causes. The one that I'll be highlighting today on the structural cause will be adenomyosis and leiomyoma, but we should not neglect the non-structural cause as well. Okay, Another one, the newer thing that I want to highlight here is that in the part of coagulopathy, um, in the part of coagulopathy, if patient is taking anticoagulant, it falls under AUBI, okay, iatrogenic, because patient is taking anticoagulant, okay, like VKA, vitamin K agonist, antagonist. But if coagulopathy only patient in, for example, in 1 Willebrand disease, so that one falls under coagulopathy, okay. So let's start in the history taking. How we are going to be approach our first history taking. Look at the HOP at first, how they presented. So we have asked about last menstrual period. This one are common, menses, frequency, regularity, duration, and volume. So it's very hard to quantify the amount of bleeding for in a patient because a patient is wearing a pad. What type of pad they're wearing? Like is it panty, like simple panty liner or overnight pad? So if presence of blood clot or flooding, it shows that patient is having a quite heavy bleeding. Okay. Then ask intermenstrual and postcoital bleeding. And since when? This is very vital. If patient is having HMB since the menarche, so the coagulopathy must be your first diagnosis because since menarche patient already have the HMB. But if the onset is after 30 years old or 20 years old, then you'll be having the PAAL pump side of the diagnosis. Okay. Then we look at associated symptoms like patient bleeding, symptom of anemia like palpitation, and then we have pain. Where are the pain? And then dysmenorrhea. Okay, so if patient HMB with dysmenorrhea, adenomyosis is your first diagnosis. Right, first because commonly sorry, fibroid rarely come with this dysmenorrhea, except for patient with a pedunculated type of fibroid, which torsion can come with dysmenorrhea. Okay, then any vaginal discharge, any compression symptoms such as abdominal and bladder symptoms, patient can have the constipation or urinary incontinence. And then as this time,
Interrupt regarding fibroid just now. Patient will have dysmenorrhea as those submucous, submucous and pedunculated. Subserous,
okay.
if distortion, but it won't relate to the menses. Common sense,
Oh,
okay.
Okay, thank you, Prof. So next, then we ask the other side, symptom of bleeding tendency, any other chronic disorder like hypothyroidism, patient can come with HMB. And then you have to ask how they affect the daily activities because their concern is actually will affect our management later on. Okay. So next is, I think, other gynecological history, current contraception, history of sexual STI, pap smear history. Some patients come with cervical carcinoma can also present with intermenstrual bleeding. Then obstetrical history, number of pregnancy. So multiparity is the risk factor for adenomyosis. Okay, and previous cesarean section as well. So past medical history, we have liver disease with can contribute to coagulopathy, thyroid of anemia, drug history, blood thinner in iatrogenic type, and OCP. Family history of malignancy, endocrine disorder, and coagulopathy. Okay, for malignancy, you really need to ask like endometrial. Colon CA is very important in the case of Lynch 2 syndrome or hereditary non-polyposis coli. Okay, so we have a social history as well. And then you really need about concern. The concern here is actually whether patient already completed the family or not. Because if a patient with a large fibroid, you want to opt for hysterectomy or only myomectomy. Okay, later on.
I'm going to interrupt again about past medical history. To go back to the previous one. Very important, like diabetes, hypertension. This is the risk factors for endometrium, right? Hypolipidemia, Okay.
Okay, thank you. Okay, so these are the type of I've divided into several diagnoses that you might be point out to the specific diagnosis. So uterine fibroid, adenomyosis, endometrial hyperplasia, and in the case of cervical CA. So if uterine fibroid, can come with you with multiple type of symptoms. Okay, various presentation. But asymptomatic is one of the most common one, but still you have to ask these are the symptoms. Okay, if patient come with fertility problem, is very there's a whole bunch of other history that you really need to ask about the partner, about the regularity of the intercourse, like does the partner was investigated for seminal fluid analysis. So it creates another set of diagnoses. Okay, and then look for any risk factor. So we have also adenomyosis, and then endometrial CA. It look for any risk factor for a chronic estrogen exposure, like HRT, and then or endometrial hyperplasia. If patient already diagnosed with endometrial hyperplasia, normally patient already had a papal biopsy done or any drugs being given to her, normally like Mirena, for example. So you need to ask when the repeat biopsy was done, as well of the hysterectomy was offered for her. Okay, so this one later you can read. Okay, so physical examination, we have generally look for any characteristic symptom. Patient with carcinoma, normally preeclampsia. Patient have pallor, hirsutism, and insulin resistance sign like acanthosis nigricans. Vital sign, patient can be acute HMB can present you with hypovolemic shock. So tachycardia, tachypnea, you can look for the sign. So we have also BMI in the obese patient, so risk factor for fibroid and also other fibroid. Okay, so we have sign.
Right. PCOS, that is because your PCOS is very important.
PCOS for hirsutism. Then we have a sign of endocrine disorder. We have thyroid enlargement or tenderness, excessive abdominal high growth pattern. This is hyperandrogenism, moon phases, in congenital adrenal hyperplasia. So we have also sign of coagulopathy for bruising and petechiae. So we come to the gist of the examination. So it's very important to palpate for any pelvic and abdominal masses. So I think just approach like a lump and bump, like side size, tenderness. Okay, so if patient with fibroid, is good to quantify according to the gravid uterus size. So if patient is up to umbilicus, so you can say the size is up to 20 weeks of gestation. Okay, so that's one. Another one we can do, but this one is beyond our normal short case or long case. We don't do, but we can say we can do a speculum examination, can do by manual to differentiate uterine or ovarian mass. So I think if you need to know, we can differentiate how to origin is uterine or ovarian mass. So it move the cervix and it move with the mass, so it uterine origin.
No.
Okay. So
Can you repeat again just now? How do you check? You move the cervix and then move the mass?
no, we move
Huh?
if we move the mass and then we move
The
move
cervix will move.
the cervix, and then we try to palpate with non-dominant hand at the mass, so it a uterine in origin.
Your non-dominant hand is on the abdomen. Your dominant hand is in the pelvis. So you move up the mass. Then you feel the cervix go up. Then you say that it is attached to the uterus, yeah? Ini very basic. Pada Pak Intan.
Okay. Then we have if we look for any partial Douglas tenderness in the case of endometriosis. Okay, then we have to do indicate digital rectal examination to exclude any per-rectal bleeding because the source of bleeding can actually from your rectum instead of your. Okay. Another investigation first. Okay, first patient come to you, we need to do UPT. This one is to differentiate patient because if UPT positive, you won't be taking off a palm coin as your diagnosis. So your diagnosis will be like miscarriage, ectopic pregnancy or GTD. Okay, and then if negative, then you can go into the line of palm coin. Okay, so then first look of FBC. This one I think hijau. So imaging is important to know the ET, uterus size shape, any fibroid and adenomyosis or ovarian anomalies. Okay. So for the ET, if you want to look for ET, it depends on at which stage the patient is on. If patient is it's very hard in the reproductive women as we have these spaces. So this one I took from Dr. Famida. So the sizes. So that's why we ask the menses before ultrasound to check for ET. Okay, next is in the case of patient with more than 45 years old, patient ada intramenstrual bleeding or postmenopausal bleeding, because we need to proceed with PIPEL. Okay, PIPEL is very good to gain the sample, but need to be reminded that PIPEL is a blind procedure. you can like you do pipel, but the specimen might not be unsatisfactory. Okay, so if
especially in postmenopausal bleeding, because in the postmenopausal, the cervix sometimes is stenos, you won't be able to insert the pipel, so it's problematic. So normally postmenopausal bleeding, we suggest to do hysteroscopy directed biopsy. The other problem with pipel is that the patient is having heavy bleeding, you might just up there blood clots. And if you do hysteroscopy, we can do not only diagnostic. Okay.
yes. We can do therapeutic as well if we do the hysteroscopy. For example, or endometrial polyp, we can do a polyp resection during the hysteroscopy session. But hysteroscopy you need to do under OT lah, in the OT. Okay. So treatment of AUB generally was observation, medical or minimally invasive surgery or major surgery. So medical, there's a lot of drugs. Antifibrinolytic for a patient that's bleeding, progesterone, OCP, genital agonist, and anti-progestation agent. So minimal invasive in the intrauterine device like Mirena is very good to reduce the blood loss. And then in the case of acute severe HMB, you can do endometrial ablation to resect the endometrial tissue and so DNC. So major surgery, myomectomy and hysterectomy. The approach is very different, depends on the size of the fibroid. Okay.
Radiological, is there a radiological treatment?
I later slide.
Ada.
Radiological like
Okay.
okay, so for UB can present only two presentation, acute or chronic. It's more than six week, 6 months, sorry,
Months.
is it called a chronic unstable. But acute, like HMB, treat it as like hypovolemic shock. So do the airway breathing, circulation, multivitamin, oxygen, IV fluid, send for cross matching in case of patient need transfusion, and said an emergency DNC might be indicated. Okay, so last part is I will describe about uterine fibroid a bit and adenomyosis. So uterine fibroid is a FIGO classification, submucosal 012. Okay, and then we have other which intramural and so subserosal. We have also hybrid leiomyoma where there is a contact of endometrial and subserosal. So this one, if the fibroid is involved with those endometrial and subserosal, it's hard to quantify in the ultrasound. So MRI of the pelvis might be needed. So these are example of ultrasound of the fibroid. You can see a very well circumscribed mass, okay, with hypoechoic, but hypoechoic echogenicity, but depends on the smooth muscle density of your smooth muscle, and in the case of some of the fibroid tissue has calcified, it present hyperechoic. Okay. So treatment for uterine fibroid can be divided but we can do some radiological like uterine artery embolization. We have a new one of high intensity focused ultrasound or HIFU. Okay, so but to treat uterine fibroid is very individualized. If patient is asymptomatic, only reassuring and do a 6-monthly follow-up to look at the uterine size if increasing in size. And you need to counsel the patient if patient wants to get pregnant, how the pregnancy affect of the fibroid and the fibroid affect to the pregnancy. Patient during the pregnancy can present to you with recurrent pregnancy loss or a preterm malpresentation, malposition of the baby later. Okay, patient also can HMB, anemic and wanting to conceive. The only thing you can give is tranexamic acid add with iron supplement. Okay, because tranexamic is very good in reducing blood loss about up to 50%. So if patient presented you with comprehensive symptoms, still wanting to conceive, you need to offer her patient general agonist and offer for myomectomy. Okay, because myomectomy is the only
Not always true. Progressive symptom wanting to conceive. You can just do a myomectomy. No need to do to give generate analog. Generate analog, you give it is very big and to make the surgery easy. And nowadays people seldom give analog because when you give this, it make the fibroid soft and you cannot get the plane. So that is a disadvantages.
So last one, thank you, Prof. Last one, we have a self-fertility. If you wanted to conceive, you need to do full fertility workout first, then continue with myomectomy.
Which part
If
what of fibroid causing fertility? Not all fibroid causing fertility.
submucosal,
Which part of uterus? Definitely which
cornua,
near to the tube, see?
cornua.
Ostium, man. Or very close to the cervix is still debatable, but those close to the ostium, that causing subfertility. But that is the other way is submucous causing recurrent miscarriages. Two different things. And one is difficult to conceive, one causing recurrent miscarriages. Okay, proceed.
Okay. So last is adenomyosis. It's also endometrial gland. They are found deep within the myometrium. So these are some risk factors. For presentation is HMB, dysmenorrhea with dyspareunia. So PE can show diffuse large and boggy or soft uterus. Okay, so the FIGO also proposes several criteria for the ultrasound. So this is by the morphological ultrasonography assessment. If two or more features of this is a diagnostic kind of diagnostic of adenomyosis, because the only way we can diagnose of adenomyosis is actually by hysterectomy and do a HPE later.
Can you tell
Okay.
us the ultrasound features of adenomyosis? This one.
So this ultrasound features for adenomyosis. So you can see a very ill-defined cystic and echoic spaces. So there is a globular enlargement obscuring loss of myometrium and endometrium border. So it shows that the endometrial tissue is inside the myometrium. So you cannot differentiate where is the endometrial tissue.
The most important thing, you see the wall of the uterus, the anterior and posterior wall is not the same thickness, right?
Yes.
This one is posterior or anterior adenomyosis? Where is the bladder? If you want to know the anterior uterine wall or posterior, you look at the bladder. And
This one.
so this could be anterior because I think it's the bladder. Yeah.
I think so.
You see the thickness here is not same, right? This one and the anterior and the posterior. Kat mana? Situ boleh? You see here, this is the apa ya? Tak apalah.
So just like Prof said just now, so you can see like there is an asymmetrical myometric thickening, like so anterior and posterior is not the same. So but you need two or more. So if A or with B or to say is the adenomyosis. Okay. Last is medical therapy, treatment, medical therapy, and NSAID to remove because patient can presented with pain and dysmenorrhea. So the other drug is quite the same with the fibroid, but for the surgical one, the only definitive treatment for adenomyosis is hysterectomy. Okay. If patient with future pregnancy is desired, we can do a wedge biopsy or uterine sparing section, but this one is rarely done. So that's all for my part.
Well done. You give I think you presented everything I wanted to present. So mine is I don't need to present anymore. Right? Where do you get you follow Dr. Fahmina's one or you do your own FID?
The mix.
Okay, next presentation. I just want to add few things maybe later after the second presentation. Okay.
My name is Ariff. I'm the next presenter.
Yes, can start, Ariff.
Yes, I'm just want to present the screen first. 5 seconds. Assalamualaikum everyone. My name is Ariff. I'm year 5 IM medical student and my supervisor is Prof Zalina binti Nusee. And so what does it feel to be young again? So some people said that when being active again and for a lady to become more about fertility and have a menstruation again. And about this patient, a 60 years old Parawan lady who underwent menopause at age 55 years old, she presented with vaginal bleeding for 4 weeks. Okay, so this the patient presented with vaginal bleeding, meaning that after the menopausing, it doesn't mean that the patient has revert to menstruation, and the patient has actually developed a condition known as postmenopausal bleeding. So postmenopausal bleeding in whatever the case is always abnormal. So it demands an investigations for the why the patient has actually have developed postmenopausal bleeding. So this is actually uh, uh, one of the under the terms of abnormal uterine bleeding also, and because abnormal uterine bleeding is umbrella term, one of it is we have look at heavy menstrual bleeding, and this is postmenopausal bleeding. So looking at the etiology of the postmenopausal bleeding itself, okay. Okay, so sorry, first is the definition of the postmenopausal bleeding. We need to know that it is a vaginal bleeding occurring after 12 months of amenorrhea in women of postmenopausal age. That is the first that we need to know, because we take into account uh, the 12 months of amenorrhea, because this is actually the definition of the menopause itself. Okay, a menopause is amenorrhea after the period of 1 year or after 12 months. Okay, so first one is vaginal bleeding after 12 months of amenorrhea, and second also we need to take into account, we need to rule out if the patient have taken any postmenopausal hormone therapy, because we expect that the patient has a cyclical bleeding. So including these two definitions, so we can consider that this patient has a postmenopausal bleeding. So to investigate further about this postmenopausal bleeding, there are several etiology of this postmenopausal bleeding that we can have. So the one that we are afraid of is the first one that I have listed, which is the endometrial carcinoma. Okay, so it is considered endometrial carcinoma until proven otherwise. So we need to rule out this sinister diagnosis first, the endometrial carcinoma. And yeah, however, please note that the most common causes is accounting for about 40 to 50% is this one, genitourinary syndrome of menopause, or the the old name is vaginal vulvovaginal atrophy or atrophic vaginitis. Huh? Sorry?
Tak tahu lah. Okay.
Or the older term is vaginal atrophy and like that. Okay. So other common causes includes endometrial hyperplasia also, and the common one also is endometrial cervical polyps. And other causes is also overlap with the causes of heavy menstrual bleeding that we just presented just now, such as fibroid or other cancers in origin. Sometimes have infection, endometrial TB, for example. Okay, so taking into first thing we have already know the etiology, the causes. Then we need to investigate it. First, our approach is as usual: history taking, physical examination, and investigation, and then manage the condition. So first, patient presented with postmenopausal bleeding. Of course, you want to know more about it. Uh, since when? Since the onset? Is it associated with any hormone replacement therapy? So we already know that if cyclic pattern, then it is unlikely. Okay, and then we know about the amount, the frequency, the blood clots. Is it painless or painful, and is it associated with symptoms of anemia that needs urgent treatment? But usually postmenopausal bleeding looking into the cause, endometrial carcinoma and vaginal atrophy or uterine syndrome of menopause, usually it will cause only minimal bleeding. Okay, but usually, but we still need to ask. All right. So, and then we look into account. First thing is to rule out endometrial carcinoma. So we need to rule out malignancy first. The points into it are first, if the patient has any constitutional symptoms that can present as cancer and any metastatic symptoms. Okay, and also risk factors for the endometrial carcinoma itself. Usually, when we're talking about risk factor for endometrial carcinoma, is risk factor for type 1 endometrial carcinoma. Later, we will see that endometrial carcinoma actually has type 1 and type 2. Okay, so these are the risk factor for it. Okay, mainly for endometrial carcinoma, it is all about, the risk factor is all about estrogen. It's about unopposed estrogen, whether it is endogenous or even exogenous. Okay, so look, as we can see, the factors that increase endometrial carcinoma. Okay, obesity can has high estrogen, including diabetes, nulliparity, and late menopause. Okay, more than 52 years old. And this is the exogenous estrogen therapy as well. Okay, and as well as tamoxifen, which is estrogen modulator receptor, if I'm not mistaken. So it can increase estrogen as well. Okay, and the other one is this one, family history of colorectal and endometrial cancer. This is because of the Lynch syndrome, which has been mentioned by uh, the previous presenter before this. Okay.
How about history of polycystic ovarian syndrome?
Yes, that is included as well.
Yes,
Usually,
very important.
okay,
What
sorry.
type of endometrial cancer you get if they have history of PCOS?
Yes.
What type of endometrial cancer? Type 1, type
Oh,
2?
type 1.
Type 1. Type 1 is
Yes.
what is type 1?
Type 1 is the estrogens that is caused by estrogen, usually. Uh, we can I will show later about that.
Okay, good.
All right. Okay. And then factors that protected against endometrial cancer is usually the one that is opposed the estrogen. Okay. Example, combined on oral contraceptive pills have progestogen, which is opposing the estrogen activities, progesterone based pregnancy, and surprisingly smoking as well for this endometrial cancer. Okay. Okay. So taking account into the patient that we are discussing just now. Okay, this is just a created patient. It's not real lah. Okay, 60 years old, menopause. Okay, so we can see several risk factor for the patient to have endometrial CA. So, okay, first is late menopause at the age of 55 years old. Okay, late menopause. Okay, and then diabetes mellitus. Okay, diabetes mellitus, and she's obese. Right. Okay, so this warrants further investigation, and even if the patient does not have any risk factor as well, we still need to rule out by using this is the next steps. We need to take the endometrial biopsy and to do a transvaginal ultrasound. So endometrial biopsy, just we have discussed just now, can be divided into the blind one, which is PIPEL, and if we don't get the sample using the PIPEL, we can go through hysteroscopy and biopsy. Hysteroscopy as well, we can see if there is any polyps as well and some other conditions. Alright. So this is the what we call algorithm, okay, of postmenopausal bleeding. Okay, we can go endometrial sampling. Okay, and it can result in normal or any abnormalities. Okay, and in transvaginal ultrasound, in the case of postmenopausal woman, the endometrial thickness, the normal should be less than 4 millimeter. Okay, for postmenopausal woman. So if it is less than 4 millimeter, we just observe, and if it's more, we can do endometrial sampling and hysteroscopy to take the sample. All right. Okay. So if all this comes to be normal, so then the most likely causes is genitourinary syndrome of menopause, or it replaced the term vaginal atrophy already. We can diagnose it clinically by physical examination to look at dry vagina, and also shiny looking, and loss of
We normally call this GSM. Macam PCOS tu, this one GSM.
Sorry?
This the terminology that accepted for this is a GSM.
Oh, GSM. Okay. All right.
Understood?
Okay. Thank you, Prof. Okay. So if it is GSM, then the treatment is easy enough, which is to give the patients estrogen cream, and that's all.
So for GSM, study showed that we don't give oral, the local is enough. And
Yes.
if we oral also, it is not effective.
Okay. Thank you, Prof. Okay. So if GSM is enough estrogen cream, however, if it is not GSM and it's something else, so example, if we do an ultrasound, we found it abnormal, either increase in endometrial thickness or any features of carcinoma. Okay. So this is the normal endometrium. So this is the uterus. Okay. The uterus, and the endometrium is about here, slightly hyper echoic one. Okay. But the thickness kalau kita kira less than 4 millimeter, sikit je. Unlike this hyperplasia one, okay, ni this one is the endometrium. So endometrium thickness is definitely more than 4 millimeter. Okay. And then for we can differentiate actually features that is more suggestive toward carcinoma than hyperplasia. Okay. Example like this, it is already polypoid lesion. So the features to differentiate hyperplasia and carcinoma, okay, includes this one. Polypod mass lesion, just like we see just now, and if there's any intrauterine fluid collection as well, okay, and already involve the myometrial invasion, okay. Unlike this one, dia tak naik sampai the myometrium, kan. Myometrium ni yang this one is hyperechoic, this one is less hyperechoic, so dia tak naik pun sampai situ. Okay. Alright. So and then that is in the ultrasound. So and then we also need to do the endometrial biopsy. Okay, either the PPL or hysteroscopy and biopsy. Okay, so it can come out in several results. Either it will be a normal result that we does not tak risau. Okay, normal result, and also if endometrial carcinoma. So endometrial carcinoma, later we see that there is type 1 and type 2, okay, and it's different in the histological type.
If it is normal, what are normally reported? Don't write normal.
Sorry, proliferative phase or secretory phase.
Yes, that's normal. If
Okay.
proliferative, what does it mean?
If it is proliferative, then it mean that the patient still having menses.
Yes,
I'm not sure.
if in the patient who's not yet menopause, it is a proliferative phase, meaning that patient has no ovulation. Because the most common cause of AUB is anovulatory. If secretory phase, meaning that this is ovulatory cycles. Okay.
But Prof. Zalina, for patient with postmenopause, so it can come with the phase also, either proliferative or secretory.
No, the postmenopause are different. Ada 4 types ke apa?
Oh, sorry, I don't go into that. So and endometrial carcinoma or either endometrial hyperplasia. Okay, and endometrial hyperplasia, the current one is 2014 WHO endometrial hyperplasia classification system, divided only into 2, which is the without atypia and with atypia. The one we concern is this with atypia because it is high risk to get cancer. Later we will see.
Okay.
Sorry?
How many percent?
How many?
To cancer.
I don't know the figure, Prof.
Okay. If you know, I give you distinction. If you don't know, it's
Okay.
a pass.
Okay, Prof. So this is just we can see a little bit of histology. So this is normal proliferative one, and this is secretory phase. Okay. So in the case of endometrial hyperplasia without atypia, as it is low risk to get the to develop into endometrial carcinoma. So the management, the first line is the Mirena, the levonorgestrel intrauterine system, give at least 6 months and up to 5 years. Okay, this is the first line, right? So this.
Because not all patients we put on Mirena. In certain cases which is not suitable for the oral medication.
Okay. Yes.
High dose progestin for 6 months, and then we repeat the endometrial sampling.
Yes. So this we can see the crowding of the glands more than the stroma. Alright. Okay. And then next is endometrial hyperplasia with atypia. So the definitive management in the case of endometrial hyperplasia, because the high risk to get cancer is hysterectomy with bilateral and saphenogeo-oophorectomy.
We still can give them oral progestin, especially for those PCOS who wants to conceive.
Yes. So we can see here the epithelial type of cell, prominent nucleolus and increased cell cytoplasmic nuclear cytoplasmic ratio and so on. Okay. Next is if it is come in endometrial cancer, then we need a grading system. Okay. So let's talk about type 1 endometrial cancer first. Okay. So type 1 endometrial cancer, this is the most common one. It consists of 75% to 80% of all endometrial cancer, of all endometrial cancer. And it is estrogen driven, which means the risk factor that we discussed just now, it is for the type 1 endometrial cancer. And it is usually preceded by atypical endometrial hyperplasia. Okay. Usually the hyperplasia with atypical type, it will develop into this type 1 endometrial cancer. So the grading system is based on grade 1, grade 2, grade 3, and this is important to determine the management later whether we want to give adjuvant therapy or not. Okay. So for grade 1, less than 5% of solid growth pattern, and grade 3 is more than 50% solid growth pattern, and grade 2 is in between that. Okay. Alright, so this is example of endometrial cancer grade 1, okay, and grade 3. Okay. Alright. So and then for type 2 is the less common one, okay, and it is however it is even though it is less common one, but we afraid of this because it is more aggressive and have a low prognosis, and as well as not responding.
Low prognosis, poor prognosis.
Poor prognosis.
The
And
most important thing to know is type 1 is endometrioid type. Type 2 is non-endometrioid. This is the two things that you need to understand.
yes. So just like Prof. Zalina said, it is not
If patient on tamoxifen, what type of endometrial CA you get?
tamoxifen is type 1 also.
Yep.
Yes.
Same as because
Yes. Alright. So for type 2 is non-endometrial histology. It does not have any relation with estrogen. It is not estrogen driven and usually occurs in an atrophic endometrium. So just like Prof. Zalina said, it is non-endometrial histology. Either clear cell carcinoma, serous cell, mixed cell, or even undifferentiated type. Okay. And then the staging is after we know that the patient has cancer. Okay. As usual, for staging. Okay. Staging in endometrial cancer is surgical staging. Surgical staging, which means after have done the surgery, which means by total hysterectomy, BSO, and also lymphadenopathy. This one is important for staging. So staging use is either I see the newest one is this one, pathologic 10M staging of carcinoma and carcinoma of corpus uteri, AGCH edition and FIGO 2018 update. So this one is meticulous one. Okay. And the one more is the 2009 FIGO and endometrial cancer staging as well.
Actually, you have to present overall, not very detailed on a specific cause.
Okay.
So you go into very detail on this endometrium. Whereas with other causes as well, like atopic vaginitis, polyps, cervical CA.
Okay. Alright. So this is the staging. Okay. And risk stratification for endoscopy is depending on the grade depending on the risk stratification. So I'm not going through that. So
you can become oncologist then, yeah.
Oh, sorry. Sorry. And okay. So
ini tak tahu lah.
so other than the So after we go back to the so just like I said before, postmenopausal, two things. First is the hyperplasia that we just discussed about hyperplasia just now, and next is the cancer, and also the atrophic vaginitis is the most common. So the other thing is not quite common. Other than that is if we see example endometrial polyp, that is also a common one. So the management in postmenopause is just to remove it, polypectomy.
What is the most important history is that sometimes they took supplement like or the makjun which is have estrogen, what you call it, phytoestrogen. That's
Yes.
very important. Most of the time, postmenopausal could be atrophic vaginitis. If you look at the history, if it is atrophic vaginitis, the bleeding is not that heavy, just staining a little bit, but not for the CA endometrium. If atrophic vaginitis, sometimes they don't really need to use sanitary pads.
Yes.
But for the CA cervix, most important thing is the postcoital bleeding. And sometimes in say endometrium also they have a discharge, vaginal discharge which is watery, okay, watery discharge. But for the cervical CA, it is all smelly, very smelly, duduk sebatu pun bau because of the necrotic tissue kan. Tissue yang busuk tu memanglah berbau. Okay, uh, anything else, right?
Okay. This is just for me. Okay.
Have you finished?
So
Hadis,
So
okay, want to listen to your hadis.
okay. This is because of so for me to be young again is to be with just we cannot turn back the time, so just be with the loved one. And
Like
this
what
is
I did, I adopted a kid. Now my kid is 6 years old, so I'm young.
yes. Yes, Prof. So because this is already the way that we do this is actually has been told by our Prophet Sallallahu Alaihi Wasallam, Nabi Muhammad. Okay, 5 things before 5, which is youth before old age, health before illness, riches before poverty, free time before work, and life before death. So we just take this into our heart and remember this. Okay. These are the notes from I just take from one of my colleagues. So I think them also. Okay. So the history taking and we just discussed it here. Postmenstrual breathing. This is actually in the summary. Okay. Risk factor we just discussed also. Okay. And the other risk factor, diabetes mellitus, drug history. Okay. General examination usually it will cause normal. Okay. So this is actually the superimposed with the previous presenter. Okay, investigation that we just discussed, and more than that. Okay, right? And the management. So this is the difference.
Important.
The difference between endometrial hyperplasia and atypical. Okay.
Do ultrasound to improve cell line so that we can demonstrate quality.
Or the cell line. Okay.
Different sonography,
All right. Okay, and these are my reference.
Okay, thank you very much.
Thank you, Prof.
I think I just like to highlight few things that which was not mentioned during presentation by your two colleagues. Go to presentation. Nora, stop please.
Okay. Yeah.
Saya boleh kontrol di sini. Boleh kontrol saya. Bapak saya kontrol. Tapi tak tahu mana ni. Next one. Okay, like a definition just now, actually we have acute and chronic. Acute is the one that usually requires admission, and sometimes they really bleed and we don't know what to do. This is acute. So mainly acute is due to coagulopathy, AV malformation, or I saw one case when I was in Oman, hypothyroid, right? She really bleeds, and sometimes we might resolve with the hysterectomy. So this is an chronic and acute. Just to highlight on this, we have two types. This is the other causes. Okay, the approach is you have to see the age of the patient. First, you rule out the pregnancy if it's in a reproductive age. And then if you see these are the reproductive age patient, so these are the possible causes. If you look here, what is the commonest? All three groups. What is the commonest cause? And ovulatory. This is the commonest and ovulatory. Because sometimes, even though patient has fibroid, doesn't mean that can have abnormal bleeding. That's why the previous slide, you see, may be seen but not a cause. Sometimes you see fibroid, sometimes. So should bear in mind. Sometimes you just see erosion over the cervix, but that is not the cause. Okay, if it's a reproductive age and ovulatory, so the fibroid, coagulopathy, heterogenic, this is the endpoint.
No, specified.
I don't know.
No,
So it's a young age of premenarche. So coagulopathy is the most important, and ovulatory because young age when they're just about to become menarche. So the issue is an ovulatory. This is the main issue. Same like the premenopausal when the egg is not a good quality. So during this period premenopausal and ovulatory also is an issue. The commonest cause. So all the phase and ovulatory. You won't get wrong if you say cause is an ovulatory. Okay. So meaning that something wrong with the cycle, menstrual cycle, no ovulation. Okay. Okay. Don't forget about the ITP, drug induced. This is the acute causes of abnormal bleeding. So history. Okay, about endometrial sampling. We used to say that if they are aged more than 45, then we do endometrial biopsy. If they are less than 45 years old, we don't do. It's not right. We still have to do for those patients with chronic and ovulation. Meaning that we treat them after 6 months still not responding to medical treatment. Then we have to take the endometrial sampling. Those who has infertility. Why infertility? Sometimes this infertility is related to the cause, polycystic. Polycystic, they are predisposed to the endometrial hyperplasia and pregnancy. So we still need to do a endometrial sampling. Diabetes also is about the same relationship, right? With infertility, polycystic, and obesity. All these are the same. And then patient with a family history of endometrial CA, and those has prolonged exposure to unopposed estrogen, for example, breast CA on tamoxifen. So all these cases, they require endometrial sampling, that regardless of their age. Okay. Imaging. We can do a color Doppler to detect the AV malformation. Sometimes in the uterus there's a AV malformation. That's why they bleed a lot. We had one case came back from UK, continuously bleeding non-stop. So color Doppler showed that there's a presence of AV malformation. Okay. The most important thing, we treat the patient, and don't forget that they have a chronic blood loss, so we have to restore the iron. And make sure we don't only treat this time, plan for the subsequent cycles. Make sure next cycle they don't bleed. They don't have a heavy bleeding. And last is to treat the underlying cause. Okay. That's all. Okay, we go to next session, question and answer, or you want to do just short MCQ? Nak buat MCQ ke apa? MCQ? Tak ada soalan?
Prof, sekejap Prof. Sebab yang saya ada soalan satu.
Ha.
For the heavy menstrual bleeding, saya ada tengok dekat guideline guideline 2018 yang heavy menstrual bleeding punya. It is said that if woman has history of heavy menstrual bleeding without other related symptoms, consider pharmacological treatment without carrying out physical examination. So why not physical examination?
I don't agree.
Okay.
Definitely, you have to see patient. Because you want to see whether she has fibroid, you want to see the endometrial thickness, whether she has polyps, she has so many things. Your question is patient is what just now?
No, because in the guideline, I know guideline is just a guideline, but it said that in the NAS guideline, woman with history of HMB without other related symptoms consider pharmacological treatment without carrying out physical examination unless the treatment chosen is Mirena.
Physical, yes, but not histological, like endometrial sampling tu. Physical, definitely you want to see. What guideline is that? Maybe endometrial sampling ke?
No, NICE guideline heavy menstrual bleeding.
Oh ya ke? Oh, saya tak baca
Yeah.
naik. Saya balik baca. Okay. Other question?
Prof, I'm sorry, I'm Hannah. I asked regarding endometrial hyperplasia. For patient with PCOS, they always have this kita chronic estrogen daripada since young. So do the cut off for endometrial hyperplasia is different from normal patient, the endometrial thickness.
The endometrial thickness, usually if they come to you without menses for few months, you can see the endometrial very thick, definitely more than 10 mm. And they can have endometrial hyperplasia when you do a sampling. You can do sampling on them. And sometimes they have atypia and sometimes it's already endometrial GA.
Thank you.
Have I answered your question?
Yeah, but just maksudnya we still take the cut off of 4 lah for patient yang post menopause.
PCOS.
Yeah.
Dia belum menopause. Kalau tidak ada menopause, mana dia tak period dah. Mesti ada but amenorrheic for a few months.
So we kalau dia PCOS
cut-off point tu jangan ambil yang menopause punya. Kan ET tu there's a cut-off point for menopause kan, pre-menopause. Don't take the post-menopausal punya cut-off point.
Maksud saya kalau patient PCOS dah post menopause, cut off dia akan sama dengan normal patient PCOS ke?
You follow the post menopause punya lah.
Tetap 4. Alright. Thank you.
Any other question? Okay, we go to MCQ. Okay, mana? Aizudin, can you answer the first question? Read and answer the question. The following statement are true regarding menorrhagia. A, it is defined as prolonged and increased menstrual flow. Aizudin. Aizudin ke siapa? Banyak din sini. Aizudin. True or false? Tak ada. Jadi mati tu makan dia kan. Aklan. Dia senang soalannya, Aklan gelak je. Aklan. B, the condition is mainly caused by coagulation defect. Just now what did I show? The slide just now. And ovulatory kan? It is associated with uterine leiomyoma. Okay, endometrial sampling is indicated especially in women above 40 years old. Above 40 tu boleh lah. Boleh. True. Okay, combined oral contraceptive pill is a management option. Senang sangat. Okay, question number 2 regarding heavy menstrual bleeding. Who wants to answer this? Natasha, mana Natasha? Tak nampak. Mana dia? Dia tengah masak nasi goreng.
Boleh tak saya tak on video?
Buat apa tu?
Tak, saya tak siap lagi.
Tak mandi lagi dia?
Dah.
Lambat dah ni, kantoi. Okay, kantoi.
Okay, endometrial sampling is indicated is defined as blood loss of greater than 150. More than 80.
Yes, correct.
Okay. Von Willebrand disease is one of the recognized causes. True. The majority are idiopathic. It's not majority kan. Okay, endometrial biopsy is indicated in women who fail medical treatment after 3 months. Fail medical treatment. Ke after 6.
Boleh lah tu.
Okay. Levonorgestrel intrauterine system is a treatment option. True.
Okay, good. Dah boleh see for final pro.
InsyaAllah.
Abir, mana Abir? Next question.
Okay, for regarding heavy menstrual bleeding, endometrial sampling is indicated in older age group. True. Von Willebrand disease is a recognized cause. True. Tranexamic acid reduce blood loss. True. And D is strong indication was with subserous fibroid. Subserosal, I think false.
You think false or true? Tak nak think ke sini?
False.
False, okay.
Endometrial ablation is one of the treatment modalities. True.
Okay, pass. Mana brother ni ha? Asfar, lama tak jumpa Asfar. Right. Ada jumpa baru ni. Baru jumpa.
Okay, abnormal uterine bleeding in women with fibroid are due to increased surface of endometrium.
How fibroid causes abnormal bleeding?
Increased surface of endometrium. True.
What?
Inability of spiral arteries to contract. False.
True.
True. Ulceration of endometrium overlying the stroma. True.
Okay.
Increase in antithrombin over the endometrial surface. False.
Okay.
Stasis changes the venous drainage. Pass.
So you didn't answer one. So your total mark is 3. Pass lah, still pass.
Okay.
It's true E tu.
Okay.
If you see the question, it's pimai tangtu kan? So I'm sure you have the past year's question, bank question. You have bank question? Ada, tak pula begitu. So make sure you practice all the questions because we also don't have a brilliant idea to make all new question. It's tired already with a shortage of staff kan? Most of the time you recycle je. So how do you collect the question? How do you collect the question? Memorize. Yeah. During the exam, you delegate kan? Delegate who should memorize what number kan? Tahu dah. Okay, next. Then we go to the OBA. Okay. Madam D. Tongki ke? A 44-year-old presented with heavy regular vaginal bleeding of 2 months duration. Her only child is 15 years old. She is neither hypertensive nor diabetic. Her BMI is 38 kg per meter square. Pelvic ultrasound showed anteverted uterus with subserous fibroid measuring 3 times 2 centimeter. The endometrial lining is 18 millimeter. Both ovaries were normal. Endometrial biopsy reveals secretory endometrium. What is the best option? What is the best treatment option? Mana brother? Ni apa ni? Macam nak sebut nama dia? Doa. Doa saya? Sister Tak apa. Doa, mana doa? Nak tengok muka tu?
I'm ready.
Ha? Not ready juga?
No.
Kan ke apa?
What?
Oh. It's okay. Okay, what is your answer? First, you analyze the scenario given.
Okay, so she's a 44 obese lady with only one child. She's not having any comorbids such as hypertensive or diabetes. Her ultrasound showed
I
anniversary.
know that this is a 44, right? It's about perimenopausal also can happen this period, okay? So with heavy regular, heavy regular meaning that it's ovulatory. If it is non-ovulatory cycle, the period it will be irregular. So this is a ovulatory cycles, okay? Within for 2 months. So it's a okay. She has also subfertility issues, right? Because her only child is 15 years old, okay? And she has risk factors of being hypertensive, no risk factors. She has no risk factors of being hypertension or diabetic. Yeah? So this one kita dah try to minimize the risk of inflammation, right? So we give this information. And she is obese. This is what I mean. How do you analyze this scenario? So ultrasound shows that she has subserous fibroid. Not submucous, right? Subserous. Meaning that it is not significant, right? Even though she has fibroid, you see, but that is not the cause. You can see, but that is not the cause. Okay. The endometrial lining is 18 millimeter. And both ovaries are normal. Endometrial biopsy. And because of 18 millimeter, she had undergone endometrial sampling. When she is 44, last time we take 40. Nowadays people take 45. So endometrial biopsy reveals secretory endometrium, meaning that ovulatory, right? Tapi dia regular menses, kan? Okay. So what is the best treatment option?
I would choose A.
Okay. Okay, combined oral contraceptive pill. What is your answer, Dua?
I would choose A.
A. Any other option?
Mm,
Atika, what's your answer? Why you should Dua? Why you choose A?
because it's ovulatory.
Normally, combined oral contraceptive pill is good for irregular cycle and ovulatory. This one is ovulatory. That's number one. Number two, she is fertile 15 years. If patient has issue of contraception, if patient wants contraception, that is another option. So we can tackle both, no bleeding and as well as contraception. Okay, what else that which is not favor of oral contraceptive pill here? Fibroid. Can we treat patient fibroid with OCPs? Can OCPs increase the size of fibroid? Macam postgraduate pula jadi. It's a postgraduate question, ya? Oh, never mind.
Sorry. Yes. I was to answer that.
You think it's a postgraduate question, is it?
I think it can.
Zul Razman. What is your answer? Zul Razman? Okay, what is the answer? Who wants to offer correct answer? Siapa nak try?
Prof, I want to offer tranexamic acid.
Okay, good, excellent. So
Yes.
you got distinction today.
Thank you.
Because first choice, and this is the first time she presented kan, 2 months je. And the cycle is regular. First choice is tranexamic acid. Start with tranexamic acid. Endometrial ablation ni if fail medical kan, and patient has 44, is not keen for pregnancy. Because OBA ni all the answers are correct. But which one is the best? All are correct. They cannot be wrong. OBA ni. Hysterectomy pun betul. Tapi what is the most correct one? Endometrial ablation pun betul. Combine pun betul. But in this patient, why would we give OCPs kan? Because we have not tried the tranexamic acid. So all correct, all answers are correct. But what is the most correct one? Is a tranexamic acid. Okay, next. Okay, next. Ani Ana nak jawab. Okay, cepat Ana.
Okay, 46-year-old woman complained of heavy irregular menstrual period for 5 months. She also experienced hot flashes. Previously, her menstrual pattern had been normal with no history of any gynecological problems. Her grandmother died because of endometrial cancer. On physical examination, no abnormality detected. Her hemoglobin was 11.5 and the cervical smear was normal. What would be the most common cause of her heavy irregular menstrual bleeding?
Can you analyze the...
So she is a 46-year-old woman having heavy irregular menstrual periods. And she also experienced hot flashes. So this could be perimenopausal symptoms.
Irregular menses, hot flashes kan? Perimenopausal.
And then she has family history of endometrial
Previous
cancer.
menstrual pattern have been normal. Before this, there's no issue.
And then she has family history of endometrial cancer. And hemoglobin is slightly low.
So it could be if she said family history of endometrial cancer. So risk factor for
Endometrial
carcinoma. Okay.
So the most common cause would be anovulatory cycles.
The rest, why that is the most common cause? Adenomyosis correct or not? What are the clue given to say that this adenomyosis is correct?
There's no dysmenorrhea.
Because you cannot simply put answer and it has to be appropriate with the scenario. But what is the most correct answer? You cannot give wrong answer here. It's very difficult actually to do OBA. You really scratch your head to make sure that all the answers are correct. That's why anatomy, we cannot do anatomy OBA. How to make it the most correct? Itulah kan anatomy.
So next question.
Okay, boleh. Kita dah jadi. Cepat, next. Siapa?
Ada siapa-siapa nak jawab?
So, sorry, Prof. Just now the answer is anovulatory cycle.
Yep.
Oh, okay.
Setuju tak? Decision student ni?
Setuju.
Okay. Saya pilih. Saya bagi Rahana pilih.
Saya pilih. Syaki.
Okay, cepat. Ni, girlfriend dia pilih. Tak boleh.
Okay, so PSM is a 40 years old lady, para 4, who presented to the ONG clinic with regular heavy vaginal bleeding. She smokes 20 cigarettes per day and she is sexually active. Upon examination, she looks pale and has a body mass index of 40 kg per meter squared. Transvaginal ultrasound shows a normal size uterus with endometrial thickness of 8 mm. Hysteroscopy shows no abnormality. The recommended treatment for her would be, so first of all, she is a 40 years old lady, which is still in her reproductive age, para 4. She probably had completed her family, but need to ask. So patient also had regular heavy vaginal bleeding, which is we already can rule out the anovulatory causes. Her risk factor is she had an obese BMI. She also had symptomatic anemia, whereby she had look pale, and there is thickened endometrial, which is more than 4. So I think the causes of her abnormal uterine bleeding would be so the recommended treatment, I think and ovulatory. Mirina is like macam OCP, but intrauterine device of OCP. So I think CD and E is the last resort. So it's either AUB. I think I would choose A.
A, cyclical noetisone.
Yes.
Any other answer? Ariff, yang Ariff.
Saya nak saya nak bagi B, Doktor.
Sebabnya reason?
Sebab because I think okay because dia lagi senang lah. Dia
senang.
Dia letak je sekali, lepas tu
Betul je.
Itu boleh. Daripada makan banyak.
The answer is B, but your reason though is not valid. Why you put Medina not giving the cyclical noetisone? Because patient ni heavy smoking, kan? She smokes 20 cigarette per day, heavy smoker. And then she is also obese, BMI level 40. So we do not want to put her on this cyclical noetisone. That's why I put her on Mirina. Mirina ni is the effect is a local effect, mainly on the uterus only. Whereas the A2 is a systemic effect. Okay. The rest two is still correct, but not yet lah. Because we didn't give a history of failed medical treatment ke apa kan. Okay. Ada lagi? Please. MP ni nak ke? We have 5 minutes je, tak payahlah. Tapi sometimes I want you to know how to answer PMP ni. PMP ni kan very important. So you want to tell Prof Azam tunggu sekejap 15 minutes.
Memang sepatutnya start 10 suku.
Okay. Cepat. Siapa nak buat ni lah? Mohana. Ada orang pilih Mohana. Cepat.
Ya, saya. Pandai petik nama. Okay, so 49-year-old Malay lady, para 2, works as cleaner, primary school, presented to gynae clinic with history of heavy and irregular vaginal bleed for the past 1 year. Ada foul smell discharge in between the menses. She is a known case of hypertension and diabetes on medication. So if we analyse this trigger, patient actually dah at the age of not reproductive lah, more than 45, tapi still can be conceiving, para 2. And then ada history of HMB, IMB, AUB lah, abnormal uterine bleed for 1 year, so it's chronic one with foul smell discharge in between the menses. It could be some infection ataupun dia nak mungkin nak boleh juga suggest sebagai CA sebab dia ada intermenstrual bleed juga. She is a known case of hypertension and diabetes on medication. Ini is risk factor for any endometrial causes, macam endometrial hyperplasia atau endometrial cancer. So list the differential diagnosis and give reason. Kalau for me,
Okay, through differential diagnosis.
kalau untuk differential diagnosis, I think the first one I will put malignancy causes, which is jangan nak tahu endometrial atau CA dulu. I think I will put cervical cancer dulu, and then because of
Put endometrial first. Kalau di paratan je. Kalau di paratan, I put that cervical CA. But
I'm
still,
sorry?
I will put because she is paratus. If she is paras A ke apa, I would put is cervical CA as first. But doesn't matter, still correct lah.
And then endometrial cancer,
Endometrial CA, cervical CA lagi.
endometrial hyperplasia.
Boleh lah. But normally discharge to in between tu, that is very informative tu. Lagi apa lagi? What else?
Boleh PID.
Oh, dua.
Disease.
Itu berbanding endometrial CA juga. Lagi? Discharge.
PID tak boleh Prof?
Boleh. Lagi?
Okay.
Tak tiga, tapi you bagi banyak-banyak.
Oh, okay.
But for you all, those who list more than 3, but you simply list, we just take first 3 je. If the first 3 tu salah, habis lagi. Even though yang bawah tu betul. Because we know that you all ask us to, sometimes you're not sure, you just listed kan? We choose the first 3 je on top tu. Kalau the first 3 tu salah, habis lah. Sometimes kita minta 3, you bagi 5 kan?
Kalau masa tu, I think I will put bila dia irregular vaginal bleed, I will consider juga for any polyps.
So another thing is that ovarian tumor, ovarian secreting hormones. Okay. PID, yes. CA cervix, CA endometrium. Okay. Okay. Next.
Prof, bacterial vaginosis boleh ke?
Bacterial vaginosis.
For smelling discharge.
PID tu can be bacterial vaginosis ke apa, because PID ni infection dia multifactorial organism kan. That's why you put PID. Okay. Next.
Saya juga ke macam mana?
Pilih bagi dia orang ni pilih. Sekarang saya pilih. Kalau apa-apa kau marah dia berdua ni pilih cepat.
Saya ke?
Haziq, ni nama Haziq. Haziq ni nama saudara saya. Mana dia? Haziq mana? Syakir dah sakit kepala dah. Where's Haziq? Pergi toilet dia? Zafira? Cepatlah ni. Prof Azam pula punya kelas. Zafira, what are the relevant history which you ask pertaining to the differential diagnosis? Meaning that kita pertaining to differential diagnosis. So, if you give 3 differential, you answer according to your punya number 1 punya answer. Okay, because it could be 5, 6 courses kan. So, relevant history pertaining to the differential diagnosis kat atas tu. Because we don't want you to simply answer kan. Kita minta nak mark. So, what pertaining to CA cervix, CA endometrium, and what else?
Assalamualaikum, Prof.
Salam.
Okay, saya try lah. So the for endometrial CA tadi kan. So we ask for the constitutional symptoms. More history kan? Soalan for history kan? Risk factors macam unopposed estrogen, early menarche, late menopause, obesity, all the PCOS risk factors, such as obesity, diabetes mellitus, use of hormonal therapy, HRT, if the patient on drugs for breast cancer such as tamoxifen, and family history. That one is for endometrial cancer.
On your differential. You answered the number one issue in the meeting. Two other questions you want to ask. So you want to focus. Otherwise, you just simply record out.
Sorry, tak dengar sangat, Prof. Oh, symptoms. Alright. For cervical cancer, constitutional symptoms as well. And then other symptoms such as postcoital bleeding.
Yes, postcoital bleeding.
For PID, ask for symptoms of infection such as fever, any pelvic pain, any.
Postcoital bleeding lagi apa? You need to ask the most important yang symptoms tu for all, that is general. What is specific for CA cervix? Postcoital bleeding,
Previous step punya.
ni kan, because dia kata discharge in between. Smell discharge kan, okay, dah ada di situ. What else? When was the last pap smear taken? Kan, and then what else? History of multiple partners kan? History of excluding infection. The husband tu ada tak terkuat, dia pun ada tak terkuat. History, right? So these are the questions that we expected from you. Not just the gitu kan? Okay? For the endometrium?
Tak dengar. Hello?
For the endometrium, that one for the cervix.
Endometrium apa? CA endometrium symptoms.
History.
All the risk factors. All the family history, colorectal cancer in the family. PCOS punya risk factors.
Okay, good.
Use of HRT.
Tamoxifen, any supplement, kan? Okay, next lah. Okay, number 3. Okay, Nur Amirah Izzati.
Okay, Prof. Now,
Important findings you should look for during physical examination. Sometimes you look at the marks kan. Sini kita bagi 3 marks. Maknanya satu answer tu 1 mark. Sini 6 ni we expect from the each of your differential tu you give 2. So that is how you answer. You tengok soalan tu. Dengar tak sana tu? Can you hear me?
Yes, dengar.
Boleh, bro.
Okay.
Okay, so from general examination, firstly we look for if patient is in stratification or not, because one of the DX the PID. And then cachexia or not for CA, and then also signs of anemia because of bleeding. And then from also look for if patient is obese or not, and also in signs of insulin resistance.
Okay, good.
And then from for abdominal examination, I look for any palpable abdominal distension and also palpable mass.
Not yet finished.
Yes.
For general.
For general, lymphadenopathy.
You have to look at her blood pressure kan. She's kan. Tengoklah BP dia berapa. And then boleh control diabetes, right?
Yeah.
Otherwise tak payah lagi senario ni. Kan? Just want to see whether you are thinking or not. Okay, what else? Then we go to the specific examination, abdomen.
Abdomen, look for abdominal distension and also abdominal mass. ascites. And okay, and then um, uh,
Vaginal examination is important, right?
then examination. Speculum examination.
Yes, what do you
Yes. Sorry, Prof.
see? Yalah. Speculum, what do you want to see?
Look for any vaginal discharge.
Good. Lepas tu,
Um, um,
colour of discharge, kan? Colour of discharge is greenish ke apa ke, is it fishy, apa? Fishy smell ke? BB tu. What smells that? Arif? She order.
Fishy smell.
Fishy, bau ikan. Tapi tak tahu aku pasien bau siang ikan kau juga. Dia bau siang ikan dia sendiri. Okay. Lagi? Okay, kita mulalah.
by manual examination.
By manual. It's not yet finished. Speculum. Ini tengok saja.
Cervical mass.
Look for any bleeding kan. Kalau bleeding tu fresh bleeding, amount of bleeding, clots ke, any mass over the cervix, right? Kalau differential cervix kan? Ha. 5 marks ni. Banyak kena jawab ni. Tak cukup markah. Bagi 2 je lah. Okay, number 4. Apa ni? Oyum.
Yes, Prof.
What investigation would you like to request?
So, for the investigation, I would like to divide into bedside, blood and imaging. So for the bedside investigation, I would like to do full blood count to see the.
Side ke tu?
Oh, tak. Bedside diagnostic.
Oh kan, diagnostic tu.
Diagnostic tu, because the patient is the diabetes.
Tak payah bedside dah, bukan diabetes. Hantar je ke.
Okay. Okay, and then for the blood investigation, I would hantar full blood count to see the severity of the anemia because the patient is currently bleeding. So and also to look the white cell count to rule out any infections. And then for the
banyak lagi nak buat tu. Kan ultrasound you all suka buat ultrasound kan? Tak apa.
okay, for the saya terus proceed to the imaging je lah. And then for the imaging, I would like to do the ultrasounds to look for the endometrial thickness.
Lagi?
And also any any growth in the uterus.
Lagi? After ultrasound,
Evidence of the malignancy such as the polypoid shape, collection, something like that.
Makan lecture je ni, 3 marks je.
Makan 3 marks je. Apa lagi lah?
You just list down je kan? Sebab dia tak bagi reason pun. If you look at something, you know how much you should answer. Okay? So you just list down full blood count, fasting blood sugar. So each ni we give half mark. So,
okay.
High vagina swab kan dia ada discharge kan?
Yes.
So apa nama?
Vagina swab.
Ultrasound, abdominal, transvaginal lagi
For the
right? Pap smear kalau dia belum buat. Then what is important? Endometrial sampling.
Yeah, in the invasive investigation such as endometrial sampling, PayPal and also hysteroscopy.
Itu je jawapan dia tu.
Alright.
Okay, we want to proceed or finish?
I think I will give to other people chance to ask the next question.
What I mean is kita nak berhenti ke kita nak sambung?
Oh, okay. Tak tahu.
Ha? Tak reply lagi. Kita tunggu sampai Prof Azam reply. Jom, start. Moh. Ada. Kila Azli. Mana Kila?
Yes, Prof.
Yep.
Open for the questioning. She is Paratu her last childbirth was 13 years ago. Bleeding is heavy recently. She started to have easy fatigability and unable to do her job. Okay, she is diabetes, oral hypoglycemic agent. An examination, she's obese, BMI of 35 kilogram per meter squared. Her pulse rate is 100 beats per minute and blood pressure of 120/85. Normal. No mass palpable on abdominal examination. Speculum examination reveals chronic cervicitis. Transvaginal scan is done and pap smear and prepared sampling are decided for her. The ultrasound picture is shown below. Describe the ultrasound finding and give the differential. This ultrasound the endometrial thickness is more than 4 millimeter.
Ada tulis kat situ kan?
25 25 millimeter. And then give two differential endometrial hyperplasia.
Tu macam Hana pointing out tu. Apa dia?
Hypoechoic.
That is what they call cystic in nature.
Cystic.
Ya, lagi.
And then
itulah.
okay. Okay, two differential diagnosis would be the hyperplasia, endometrial hyperplasia.
Okay, lagi.
And also
Two differential.
another one endometrial cancer.
Okay, so you can give three marks, three answer kalau you nak. You can answer endometrial hyperplasia with atypia, or endometrial cancer.
Okay.
Next is Rusyaidi. Rusyaidi dah pandai lah. Rusyaidi lah bagi peluang dia present tadi mesti pandai jawab. Rusyaidi silat. Rusyaidi. Salma Khalifah.
Assalamualaikum, Doktor.
Waalaikumsalam. Yes, Salma.
Okay, so question is, a blood investigation is done in view of her heavy vaginal bleeding and her hemoglobin level is 5. So she has severe anemia, and she also mentioned above that she had also symptomatic anemia, easy fatigability. So question is, what is your management regarding her hemoglobin level? So her hemoglobin level is very low. So I would offer blood transfusion, packed red cells.
If you look at the marks, it's 6 marks.
6 marks.
You have to answer quite a lot lah.
Okay.
Patient came in the outpatient, right? So you admit patient. Then?
Oh, okay. Admit. Admit patient. Resuscitate the patient. We ABC. We go to.
How much is the blood pressure? no need to resuscitate her. Okay. But she's tachycardic, right?
Yes.
So I don't think she requires resuscitation.
Oh, okay.
What else? Before you do blood transfusion, what do you do?
Sorry, before?
Before you do blood transfusion, what investigation you do before giving blood?
Oh, we do the GXM and GSM. Cross matching.
Yes. Group and cross matching.
Yes.
What else? Transfuse. After transfuse, you see whether there's any blood reaction.
Yes, if there's any allergic reaction,
Transfusion,
any fever.
hemoglobin. And don't forget that patient has a chronic blood loss, so she might require iron as well. Then you give parenteral iron, you calculate how much iron she's needed, right? So these are the answer that we expect from you.
Oh, okay.
Okay. Siapa nak minta tahu? Saida. Nak Rusyaidi. Rusyaidi cepat, ada orang request Rusyaidi juga. Mic problem ke? Tak apalah. Rusyaidi mic ada problem ke? Tak apalah. Siapa Syarafina dah?
Ada. Belum.
Boleh jawab kan? Pasal malu tu tutup kipas.
Tak.
Berapa malu orang dia. Okay.
Hello?
Ya.
Oh, okay.
Answer.
Okay, so patient started on tranexamic acid to help her bleeding. 2 weeks later, investigation results are as below. Pap smear HPV negative, cytology normal, pipal fragmented pieces of tissue inadequate for evaluation. What is your next step of investigation? This its advantages and disadvantages as compared to people. Okay, so my next step of investigation is hysteroscopy and sampling. So the advantage of hysteroscopy compared to pipal is that we can visualize the focal lesion or hyperplasia. But the disadvantage is that it's a procedure that we need to do in the operating theatre and patient is under anesthesia. And
Not necessarily in the room.
maybe sedation ke.
Can be
Tak sure.
under office procedure. If
Okay.
monitor of the scope. Disadvantage could be cost.
Cost.
Then is slightly invasive, right?
Mm.
And complication of the water retention too, not really lah because this is just diagnostic. The advantages too, compared to people.
Advantage is that you can visualize to the specific site of hyperplasia.
You can take a specific site for biopsy, specific to directed by biopsy. What else? You can do as therapeutic as well.
And therapeutic.
Disadvantage? Sometimes can cause compression. Sometimes we need to dilate the cervix. We overload too if we do therapeutic lah. But if you answer also can give marks. Okay. So how much marks? 6 So at least you have three advantages, 3 disadvantages kan. That's how we mark actually to make it easy.
Okay.
Okay. Next. Siapa? Uzair. Mana Uzair?
Yes, Prof.
Yep. Answer the next trigger, please.
So the next trigger, hysteroscopy shows endometrial hyperplasia with polyps. Polypectomy done, the histopathology reveals simple endometrial hyperplasia without any atypia changes. The patient keen to reserve her uterus. Outline the general measure in the management of this patient. So first, the general measure for the management of this patient, I would like to control the uh, heavy menstrual bleeding for this patient. So the heavy menstrual bleeding, we can control either give OCP or tranexamic acid. For acute, we can give tranexamic acid or COCP as well. So and for the endometrial hyperplasia without atypia features, so this endometrial hyperplasia without atypia features usually and unlikely to be undergone malignant transformation. So I would like to have follow up for this patient at least 6 monthly to annually. So for the endometrial hyperplasia, we can suggest patient to have LNG, IUS, intrauterine. Sorry, Prof.
Well,
Yeah.
you should read the question properly. Outline the general measures.
Uh,
General measures, meaning that it's not specific. Because if you the question number 9 too, option of medical treatment meaning it's specific. So the number 8 too, general measures. What problem? What are the problems in this patient? Obesity, lagi apa lagi? Diabetes kan. So for the obesity, you refer to a diabetes clinic. Diabetes pula. Diet clinic. Aduh. Obesity clinic So right to lose weight lepas tu for the bleeding, we ask her to do menstrual calendar kan. So this is general measures. Okay. So in the hypertension level not well control, refer to ophthalmology, kan. So these are the things that we want actually. So you really need to read the question properly.
Okay, Prof.
Okay, next, Wan Amira. Wan Amira? Tak ada.
Hello. Can I answer? Sorry, Prof. I don't know what happened to my mic. So option for medical treatment, we can give levonorgestrel IUS or Mirena. Because this one will and another one is high dose of progesterone or high dose. So for 6 months.
Hyperplasia, right? So hyperplasia normally we don't give estrogen, we give progesterone.
So induce the atrophy of
We give Mirena or progestin. High dose. Okay, good. Next. Zurain. Zurain Zuhari. Ni Z ni Zoro sama saya. Baru Zoro.
Yes, doctor. After 6 months of medical treatment, repeated endometrial sampling revealed endometrial hyperplasia with atypia. After an extensive counselling, the patient agreed for hysterectomy. Justify the hysterectomy in this patient. So number one,
Yes. How old is she?
49-year-old. I think she is already completed the family, so just justify one justification for hysterectomy, and also to prevent any further further say medical complication of and risk factor for endometrial CA, as well as what else?
What is the most important here? Completed the family. What is the most important here? Because after 6 months of treatment, repeated endometrial sampling reveals endometrial hyperplasia with atypia. Initially, it was endometrial hyperplasia, right? After an extensive counseling, the patient agreed for hysterectomy. So justify hysterectomy in this patient. So justified or not justified? Yes.
Yes.
He is 49, completed the family, and the medical treatment because initially was just 80 years. After 6 months of medical treatment, he progressed to 80 years, right?
Yeah.
35 too.
Okay.
Furthermore, she has other comorbids kan, like hypertension, diabetes. If we give her on hormonal treatment, and sometimes she further, make the diabetes poorly controlled. Okay. Next. Bukan sama tak ada. Faham tak? 11. Satu tahun lagi. Habis dah? Semua dah jawab dah? Ni lah you jawab apa?
What is your preoperative preparation for this patient? So first, I would like to do several blood investigations like GSM and also the profile, and then refer to NS for the surgery, and then like to take consent. So informed consent. So I would explain first the procedures, the complications.
Investigation tu you have not finished because she's going for surgery, right?
ECG, chest X-ray.
So before you refer her to an become without systematic so that you won't miss anything. So before referring her to the anesthetist, I would like to do a preoperative investigation such as she is 49 and then endometrial hyperplasia with atypia kan. So diabetic, hypertensive, so kenalah buat this full blood sugar, okay, renal profile, tadi
chest X-ray, ECG.
Yeah. Progression, atypia je.
SH.
Okay, DSH ke kan, okay. What else? And then you refer to anesthetist,
And then like to take informed consent from this patient, explain to the patient and the spouse regarding the procedure and its complications. And then
put the 4 marks itu tak banyak salah. Set the date lah. Okay, print sometimes dia tulis sekali BM, primat ni pasal tak ni pun tak betul. Tak ada pun dia accept dia. Okay. Number 2.
Can I ask again? Regarding pre-operative preparation ni, do we need to send for CA125 dengan buat lagi ultrasound just to rule out any ovarian pathology?
Tak payahlah CA125 is ovarian because this now dah confirm. Because now the issue no more differential yang tadi tu. Now dia dah trigger ni dah confirm dia ada endometrial hyperplasia. There's no other issue of ovarian. So kita the more trigger itu kita slowly we give the final diagnosis.
So maksudnya kita untuk patient ni kita memang nak opt for bilateral self-inject lah, even though dia tak ada apa ni ovarian cyst because of ada
49. We can discuss with her. Because this one agree for hysterectomy. Tak kata pun oophorectomy. If she wants to keep the ovary is normal, you can offer her self-injectomy. Why?
Alright.
Because self-injectomy, you reduce risk of ovarian cyst. And tu dia ada apa receptor situ? P berapa?
Tak ingat, Prof.
P berapa? This is the receptor for ovarian CA. That's why sometimes when patient going for tubal ligation, we advise them for to self-injectomy. 50% of having risk of ovarian CA. Even though being 49, ovary tu, yes, you can get menopause soon kan, but in a post-menopausal woman, ovary still have some function, especially for the libido.
Faham, thank you so much, Prof.
Dah, mana Ustaz sini jawab yang last question Ustaz? Ni, Ariff lah, Ustaz Ariff Ustaz. How can she perform solat while she is on continuous bladder drainage?
She can perform like normal solat, just to change the if want to take the wudu, just clean the area that is have a urine.
Ya. Anis Akilah setuju? Tak jawab dulu ni. Anis?
Ya, saya.
Setuju tu. Ustaz jawab kalian tadi ke nak solat just clean the area je?
From what I know, kalau macam patient on CBD, before dia nak solat tu, kita kena empty the CBD tu, and then make sure dekat dalam tube tu dah tak ada urine, and then kita clamp.
Flush lah urine tu.
Flush. Lepas tu baru boleh perform solat.
Fitria nak jawab macam mana?
Yes, Doctor. Yes, Prof. Okay.
Kami Dr. Lumrah pun dah confused ya?
Sorry, Prof. Okay. So, for my opinion, if possible for her, if it is not like menyusahkan, she can change the urine bag, and then however
lima kali lah tukar urine bag tu.
However, if kalau susah, she can just empty the urine bag and then flush the bag, and then she can just clamp it and solat macam biasa.
Macam Ustaz jawab tadi lah. Dia solat ni biasa lah. Bawa urine bag tu. Ambil uduk je. Kalau ada spillage of urine dekat genitalia, dekat tu, cuci je lah. And then solat. Okay. Tak payah nak buang-buang urine ke, cuci, empty the bag ke, no need. Okay, solat as usual. Okay, that's all.
Prof Zalina, I just want to ask for the ultrasound of kalau to measure the endometrial thickness tu, kita ambil yang atas dengan bawah tu kita gabung sekali ke kita ambil satu layer je, Prof?
Tengah tu dia punya if you want slit at the center kan, and then top and below lah.
Okay, ni kita sebab kalau ada air dalam dia, maksudnya endometrial thickness dia dah
tambah.
Jadi tak apalah. Kalau macam cell line tu
ada ukur separate, atas sikit, bawah sikit tak ada.
Kita ukur separate lah.
Tak. Together.
Okay.
Bagus, tak ada apa tanya saya macam ni. Ada air dengan apa. Okay, that's all. Thank you very much for attending my revision class today. So I wish you all the best, and inshallah you'll be my colleague soon. Who's interested in doing urogyne? It's a very dry topic, yet patient is wet. Okay, thank you very much. Assalamualaikum.
Thank you, Prof.
Thank you, Prof Zalina.
Salam, thank you, Prof.
Apa yang